for the invitation to discuss malperfusion accompanying acute type A dissection. When should repair of the aortic root be first, and when should treatment of the malperfusion be first? No disclosures. Malperfusion is a pressure deficit exceeding 15 millimeters mercury systolic. Malperfusion syndrome is a perfusion deficit accompanied by organ damage, usually the gut and legs. Listed here are 4 categories of type A dissection. All patients go directly to surgery for root repair except those stable patients who present with malperfusion and evidence of tissue damage. These go first to IR for reperfusion, then possibly to vascular or general surgery. Arterial obstruction is determined by the anatomic relation of the dissection flap to abdominal and extremity branch arteries. In static obstruction, the dissection flap and false lumen enter a branch artery and re-enter or occlude it. In dynamic obstruction, the dissection flap prolapses across and blocks the vessel origin. Finally, both mechanisms can be present together, as in the third row. Stasis in a segment of the artery can be followed by true lumen thrombosis in the no-flow segment. The total perfusion deficit is the sum of all 3 sources: true lumen thrombus, dynamic obstruction, and static obstruction. IR treatment priorities are as follows: common femoral or iliac artery true lumen thrombus, lest opening the aorta above it provokes embolic shower. Next would be the superior mesenteric artery, true lumen thrombus, dynamic obstruction, and static obstruction in that order. Finally, the celiac and hepatic, renal, and iliac arteries follow. As an example, consider this 66-year-old man with acute type A dissection accompanied by leg and abdominal pain. CT shows type A dissection with an entry tear in the distal ascending aorta as well as a dissection flap in mid-descending aorta. In the abdomen, the flap was prolapsing across all the visceral artery origins but the left renal, which was fed by the false lumen. The CT shows dissection and/or thrombus extending into the right common femoral artery and collapsed true lumen in the left common femoral artery. The patient was transferred to Michigan Medicine, and the IR procedure to restore perfusion began 9.5 hours after onset of symptoms. IR found left renal artery supplied by the false lumen, dynamic obstruction of the remaining visceral and common iliac arteries, and dynamic plus static obstruction of the left common iliac artery, with true lumen thrombus in left iliofemoral arteries, treated with thrombolysis, fenestration, and stenting. Following IR procedures, he underwent left SFA embolectomy and 4-compartment left leg fasciotomy, followed by laparotomy and subtotal colectomy, sparing the rectum. He underwent hemodialysis for 10 days. A fluid collection in the pelvis was drained several days later, complicated by bowel perforation requiring laparotomy and bowel repair. 9 months later, CT showed stable thoracic aorta. Root repair was still on hold. In this time, the patient's type A dissection transitioned from acute to chronic status. Overall survival curves in all type A dissections, comparing our first and second decades using the OR-IR philosophy described here, showed overall improved survival in the second decade due to more aggressive ICU and surgical monitoring and treatment of the post-IR patients and repairing aortic root once the enzymes start declining. The second set of curves compare OR first patients without malperfusion syndrome to those of the IR first patients with malperfusion syndrome who had fenestration and stenting first, followed by delayed repair. The curves are remarkably similar. In conclusion, with acute type A aortic dissection accompanied by malperfusion syndrome, patient survival improves in a program of aggressive IR first management of critical arterial obstruction with directed surgical treatment of damaged organs, followed by root repair when clinical status and blood markers indicate repair.